I think COVID really changed our lives, and what is important from that point of view is that we've really now gone into the next phase, and this is where this long COVID story is coming from. If we look at, doesn't seem to want to change. There you go. If you look at how COVID started, I think many of us had the experience that we really didn't understand this disease at all. And it was really over time that we began to understand a little bit about this mechanism of COVID and how this affected our patients. And as the data came through, first from China, then from Europe, and then as the pandemic developed further afield, we began to understand the pathophysiology of this disease a little bit better. And again, just to understand the inflammatory process, and there was a very interesting lecture just before lunch where one of our colleagues spoke about all these inflammatory markers and how this can generate all the complications that we did see. And in his situation, he was talking about the inflammatory processes in the vascular system and specifically how inflammation affects us. And it's the same mechanism through the ACE2 receptor that COVID affected our bodies in various ways, most notably access through the pulmonary system, and then further afield in different organ systems, the complications develop. And this is an important aspect of understanding, again, whether long COVID is really something to consider or not. Many of us saw this kind of picture. I think if you were in active medicine at the time, you wanted to run away when this patient arrived in your emergency department because you knew that their prognosis was very poor. And yet some of these patients did make it and some didn't. And it was difficult to determine which patient was specifically at risk. Our South African experience, where diabetes is a major risk factor, was really of great concern because in South Africa, we have close to 60 million people. And of these, there's a 7.6% prevalence of diabetes. So we were very worried about the fact that, as we understood from China and Europe at the time, that patients with diabetes were particularly at risk. And in South Africa, diabetes is the first leading cause of death in women and the second leading cause of death in South Africa total. Then follows obesity and hypertension. And these were major risk factors in these patients with COVID. One of the aspects in our South African experience was that our Department of Health didn't report all the cases. I think they didn't want to concern us, which was a bit short-sighted, but the actual numbers from our South African Medical Research Council in blue, you can see very carefully, the red was what was reported, the blue is what was actually happening. And you can see the different spikes with the different waves that we saw, first alpha, then beta, and then the more recent ones. But the bad one was really in 2021, going into 2022, when I think we had the highest mortality rate. So we were worried initially because we have such a high prevalence of HIV/AIDS that these patients would be more at risk. We have a 37% prevalence of HIV/AIDS in our country. Because the previous health minister didn't believe in treating this condition adequately. And unfortunately, there was a catch-up phase for us to get patients on treatment. But interesting enough, our HIV/AIDS patients actually didn't develop bad COVID. They seemed to be protected for some other reason, whether they were on antivirals, antiretrovirals, and these were protective. We also, as I said, have a high prevalence of diabetes, and it was definitely the obesity, hypertension, and diabetes were the big risk factors in our patients who had a high mortality rate from COVID. So these are just the waves to show you how they happened, and just to look at how by the third wave, we really saw the highest mortality rate, and that was in 2021. So as you know, and I hope somebody will laugh at this, let me check if you guys are laughing, not yet. So if you look at this, you know, the first trials that came out there, the abstract looked fantastic, you know, We started with hydrochloroquine. We had the whole vitamin story. Then you had the introduction of the trial, and then the actual results didn't look as fancy as the abstract had suggested initially. So I think if you look at how we learned over time how COVID would affect us, I think the same applies for long COVID as well, because this is really where we are at the moment, is to understand how this disease could prolong disease in certain patients. I won't spend much time on ivermectin, but again, it was also something that we had to deal with in South Africa, where there were a certain percentage that believed that ivermectin was a wonder drug, and as we know, there's absolutely no data to support that. So we managed the patients looking at the European experience with the way that really just at the time was the most recognized intervention. And what we did find is that the Actemra or tocilizumab combined with remdesivir as an antiviral agent early on actually did make a difference in the outcome of the patients, but it depended on when the patient could get to you and how early your intervention was. Oftentimes, the patients arriving with pulmonary edema, like you saw in that X-ray, were too late. And we also had a situation where our hospitals were overwhelmed and we had people sitting in cars on oxygen, and at times even on lazy boys in the departments where tea rooms were changed into emergency rooms. And we were applying these supportive medications to patients because there weren't enough ventilators. The COVID studies, most of these were sort of later available, and it showed us that that approach of what we did was really the way to go. And we did manage to save quite a number of patients if we were able to do this early enough. But I think the biggest recovery came when the vaccines became available and our patients were able to receive vaccination. So if you look at long COVID, and I think this picture, and I'm sure people who work in general medicine can testify to the fact that there could be a symptom in every single possible part of the body. The most commonly being neurological, and I'll explain a little bit about that now. But the most important factor has been this fatigue that people complain of. But it can really take any picture. You take a picture, I always say it's untier for our Swiss colleague. And it just shows that we really don't understand if the symptoms that the patient presents, does it reflect long COVID or is there something else going on? So it's a real conglomeration of what can happen and how the patient can present. Interesting enough, there is now a definition, so it must be one or more clusters of symptoms lasting more than 3 months after the COVID event. And the patient had to have had symptomatic COVID. So 6% of those included in this cohort of patients that they examined, 1.2 million people, had very severe symptomatic COVID. And they tried to adjust these numbers for the pre-COVID health status. So did the patient have comorbidities? Did they have diabetes? Did they have obesity, hypertension, etc.? And what they found that 2.2% of this cohort specifically that was examined, this large number of patients showed cognitive problems. Some had persistent fatigue, body pain, and mood swings, and ongoing respiratory problems in about 3.7%. The majority of these patients were female, and they had previously been hospitalized, and some for a longer period of time, and if not, then at least for 4 months duration. And 38.4% of these patients had 2 or more symptoms that overlapped of the ones that I showed you on that picture of the female body. Myocarditis is a definite finding that we saw with COVID, but luckily it seemed as if the myocarditis resolves completely and that there's no long-term cardiac problem in these patients. It fully resolved, and there was at one stage a query whether this could be associated with the COVID vaccine, but there was absolutely no association and no evidence of it. Some patients did have arrhythmias. There's a post-COVID tachycardia, which again improved over time. Some people had a postural tachycardia syndrome. And again, this was something that was observed and did improve over time and wasn't persistent. That's just a graph really of the different myocarditis presentations. The neurological complications, in COVID, really, you get an exaggerated inflammatory response. I'm sure you saw D-dimers that were above 20, ferritin levels 18,000, and interleukin-6 levels that were off the charts. So there was a definite alteration in the nervous system due to the release of these cytokines. Many people describe the brain fog, but it's interesting that many of these patients had been treated for depression before or had some kind of psychiatric involvement pre-COVID. There were some findings in the frontal cortex and limbic system on MRI scanning on some of these patients that were examined. But again, this was associated with anxiety, depression, memory loss, and cognitive impairment. Sorry about the depression, that was spelled wrong. It's important that the ACE2 receptors exist in the endothelial lining in the brain as well. So there's a loss of integrity of the brain's protective processes. So they found some abnormalities in the astrocytes, and especially due to glycoprotein receptors that could give abnormal PET scans, and in the limbic system showed what's called cold spots. And also some patients had derangement of smell, and it was found that there were some changes in the olfactory system. Many of patients also had sleep disorders and had some cognitive ability impairment and chronic pain, which could take the symptoms of myalgia or body pain generally, but all of these were self-limiting and didn't persist. There was another survey done more recently, 2022, in the clinical infectious diseases, and also followed on by an article in Neuron, where they looked at the fact that patients who'd received the booster vaccine were protected, and patients who were not vaccinated had a higher risk of long COVID symptoms, or patients who didn't have the booster vaccine. So the fact that the vaccine has changed the face of COVID, nobody can really argue that. And I think speaking to your Minister of Health last night, and also to the President, the Vice President, that this made the difference also in the Dominican Republic. So the moment the vaccine became available, I think it just changed the face of how COVID was affecting us. And now with long COVID, we see exactly the same thing, that patients who did not receive the vaccine had a higher risk of developing long COVID symptoms. In this particular survey, mainly females were affected, more females than males. Comorbidities definitely played a role, and again, obesity, diabetes, and hypertension were the most important. Interesting, smoking did not seem to affect it, and as I said, HIV/AIDS, which we thought because of the effect on T lymphocytes could have an effect, actually didn't. And interesting again that whites were affected more than any other cultural group. So 60% more in this particular survey, which was done in America. Looking at lung complications, again, from that point of view, many factors can affect the lung, especially because this is the primary source of where COVID would enter the body. But the commonest presentations that we saw were the embolic phenomena. We had some patients that presented with massive pulmonary emboli, and we actually had to thrombolyze them. And interesting enough, in those patients where we thrombolized them, we avoided having to ventilate them. We did aggressively in South Africa use anticoagulation, keeping the factor 10A level at 0.8 to avoid any bleeding complications. And we did find that this did mitigate against any long-term pulmonary complications. But it would be interesting to hear what other countries and their experience was. Some patients did develop pulmonary hypertension, but again, it depended on how initial management was managed, or the intervention in how this was prevented in the long run. So again, this is not a symptom apart from shortness of breath with exercise that many people complain of in the long COVID symptom complex. It seemed to be more neurological, fatigue, and the muscle pain, as I've mentioned. If we look at other respiratory symptoms, again, shortness of breath, patients with pulmonary disease pre-existing, that could, for example, patients with COPD, it could show that there would be long-term complications on these patients, and especially if they needed ventilatory support or high-flow oxygen. But again, here, steroids did seem to make the difference in the long-term outcome of patients. In my own group, in my personal experience of patients over the 3 waves, I looked after about 500 patients, more or less, and we definitely found that by using this high steroid intervention early, carefully, monitoring the sugar, making sure that all risk factors are looked at, making sure that fluids are given but not excessive, and adequate oxygen supply, physiotherapy with good phlegm clearance, and then also the use of anticoagulation carefully to avoid complications of bleeding, really did seem to work and gave us the highest outcome and survival rate of these patients. Of course, there were many that didn't make it, and they often presented late or at a time when we didn't have ventilatory support available or an intensive care setting, because there simply weren't space. At the moment in South Africa, there are no specific clinics set up. It's early days to really understand whether this pathology would take the same course as something like MS, meningoencephalocele, or the chronic fatigue syndrome that is such a difficult thing to determine. And again, we found that patients that were well motivated and treated and embarked on a good rehab program actually returned to work without any long COVID or so-called long COVID symptoms. The psychological impact, absolutely, also to our staff and doctors, the fear, the uncertainty that this pandemic brought had to be recognized, and many of our staff still undergo psychologic counseling to ensure that they are supported. Now, that had nothing to do with long COVID, but it is important to remember that this impacted people. And having to see such a high mortality rate and having to deal with families definitely took its toll on our staff. We need to do better in the future to try and prevent this kind of pandemic. I think we did learn a lot from this, and hopefully we would never in my lifetime have to see this ever again. COVID has definitely changed our lives. I just want to take 2 seconds to advertise the MERSIM Congress that will be in Krakow in May, and especially to young doctors, there's an opportunity to present papers. We'll give you the detail. There'll also be a symposium with the ISIM, where we're combining with the European Association for the Study of Diabetes under the leadership of Chantal Mathieu to just support the Polish Society of Internal Medicine, but also the McMaster University that runs this program on an annual basis. And I hope that if you can't get there personally, you can do it virtually by going onto the website, the MERSIM website, and to see how you can register and be part of this program. So with that, thank you very much, and I trust that there'll be questions. Thank you.